Welcome back to part 3 of our 15-part training series. If you're a medical coder, an auditor, or working in practice management, you already know that EM coding is literally the beating heart of outpatient billing. Today's explainer gives you a foolproof framework for classifying new versus established patients. We're going to lock in the exact CPT rules so you can navigate this every single day with total confidence.
Because let's be real, you know exactly what's at stake here. Mixing up these codes, it's one of the most common triggers for a billing audit. A simple misunderstanding of a patient's status can lead to immediate claim denials, delayed cash flow, or honestly, an absolute compliance nightmare. We need to get this right every single time.
Okay, so here's our roadmap for today. We'll quickly cover the EMM coding stakes, defining new versus established, our 3-step decision tree, specialty versus subspecialty nuances, an interactive hospital case scenario, and finally wrap up with takeaways and a peek at part 4.
Let's start with section 1. The EM coding stakes.
So, why are we zooming in on this? Well, understanding this distinction is absolutely crucial. Getting that evaluation and management level right ensures you get accurate reimbursement and, just as importantly, bulletproof audit readiness. You know E&M codes aren't just arbitrary numbers, right? They reflect the true complexity and time involved in a patient encounter. By classifying a patient correctly, you're laying the groundwork for fair compensation and ensuring your documentation can stand up to any outside scrutiny. Higher complexity means a higher level, which means higher payment, but only if that foundation is totally compliant.
Moving right along to Section 2, defining new versus established.
Let's look at the official CPT definition. A new patient is one who has not received any professional services from the physician or another physician of the exact same specialty and subspecialty in the same group practice within the past 3 years. So the absolute kicker here is that strict 3-year timeline and the criteria matching the exact same specialty and subspecialty within a single group. Essentially, if they're new to the specialty, they are a new patient.
On the flip side, an established patient has crossed paths professionally with that specific specialty group within that same 3-year window. The keywords you've got to burn into your brain are same group and exact same specialty or subspecialty. That exact same phrasing, that's where the magic happens, and it's where we need to be laser-focused.
All right, Section 3, the 3-step decision tree. To make this perfectly actionable when you're actually auditing a chart, let's use a mental flowchart. Just ask yourself these 3 questions in order. Step 1. Did the patient receive professional services from this provider or group in the past 3 years? If no, boom, stop right there. It's a new patient. If yes, move to Step 2. Was it within the exact same specialty? If no, new patient. But if yes, you literally have to move to Step 3. Was it within the exact same subspecialty? Yes means established, no means new. It's really that simple.
Which brings us to Section 4, specialty versus subspecialty nuances.
Because that Step 3 we just talked about, that is the trap so many coders fall into. We have to clearly distinguish between a specialty and a subspecialty. Think of broad fields like internal medicine, pediatrics, or surgery. Those are specialties, but a narrower focus that requires extra training, like cardiology, pediatric neurology, or spine surgery, those are subspecialties. You've got to know your provider's exact credentialing taxonomy to code this accurately for sure.
Let's test this in Section 5, our interactive hospital case scenario.
Picture this real-world gray area you might literally see on your desk today. Dr. Sharma, who is in internal medicine, sees a patient at Apollo Hospital last year. Today, Dr. Verma, a cardiologist at the exact same hospital, sees the patient for chest pain. Take a second to think about this one. Same hospital group, same 3-year window, but we're moving from internal medicine to cardiology. Is this patient new or established for Dr. Verma?
Well, if you guess new patient, you hit the nail on the head. You're absolutely correct. Even though they're in the same hospital group and it's only been 1 year, cardiology is a distinct, narrow subspecialty compared to general internal medicine. So, following our decision tree logic, because the subspecialty is not the exact same, Dr. Verma has to bill this as a new patient visit. This is a classic example of how mastering these tiny nuances ensures you're capturing the right reimbursement for the higher complexity of a new patient workup.
Finally, Section 6, takeaways and Part 4.
Let's lock in what we've learned today. Always remember, the whole purpose of E&M coding is to accurately reflect the complexity of the service provided while staying fully compliant. The exact specialty and subspecialty match is the ultimate deciding factor, and that 3-year rule? It is absolute. No exceptions. So you've now got the master key for patient classification. You will definitely want to join us for Part 4 of our training series next, where we're going to tackle the level selection blueprint, comparing medical decision-making components versus time guidelines. You won't want to miss it.
Thank you so much for joining this explainer. Think about your own desk right now. How many claims are currently sitting there in denial simply because of a misunderstood subspecialty nuance? Keep practicing those decision trees, stay compliant, and decode healthcare with Harshal.